Hi, and welcome to Closing the Gap, Evaluating Rural Communities with a Health Equity Lens. My name is Samantha Tucker, and I am the Evaluation Manager at Healthcare Georgia Foundation. Healthcare Georgia Foundation is a statewide, private, independent foundation located in Atlanta, Georgia. Since our establishment in 1999, our vision has been to achieve health equity among Georgians, and this is seen throughout our grant making. The Foundation's evaluation philosophy is one of continuous improvement, understanding what works and why, and examining our role in it. Accordingly, the Evaluation Resource Center, or ERC, was launched in 2012 and represents a shared commitment to better outcomes where evaluation is integrated into all of our grant-making activities. The ERC offers evaluation services that are tailored to help our grantees and other health nonprofits achieve better outcomes through coaching and technical assistance, a program evaluation toolkit, and access to our ERC partners. For more information and free access to the toolkit, please visit www.georgiaerc.org. In 2017, the Foundation launched the Two Georgias Initiative, a multi-year place-based grant-making program designed to address health disparities and achieve health equity in rural Georgia. Before we get into evaluating with an equity lens, it's necessary to understand the background, goals, established coalitions, and technical assistance provided with this initiative. Before the launch of the initiative, the Foundation mined data, held listening tours and forums throughout rural Georgia, commissioned papers, engaged civic organizations, and strategically planned and designed the initiative. Throughout the process, our guiding principle was, and still is, flexibility and choice. And we found that the most important element to all of this was gaining trust and establishing relationships with the rural communities. Out of the planning and designing came the initiative goals: to achieve greater health equity, improve health and healthcare, build healthier communities, improve social conditions, and build communities and organizational capacity. As I mentioned before, this is a place-based initiative, so to provide some geographical context, out of the whopping 159 counties in Georgia, 108 are rural. In June of 2017, the Foundation funded 11 lead organizations representing a cross-section of rural communities in Georgia. During the first year, which was a planning grant, they each established community health coalitions, some new, some already existing, and each coalition was charged with the task of developing a community health improvement plan. The following year, in June of 2018, each coalition entered into the implementation phase, where they put into action the activities and programs stated in their community health improvement plans. Implementation will last until June of 2021, this year, and then transition into a sustainability phase, or what we're calling our bridge year. Throughout the life of the initiative, the Foundation is providing support to the 11 coalitions through a technical assistance team. This team has assisted from the development of each coalition's community health improvement plan to meeting planning, understanding health equity, and naturally evaluating their efforts. So the biggest question a lot of funders have, and the reason we're here today, is, are your investments closing the disparity gap? And in order to know this, we have to evaluate with an equity lens. Many times, the effects of an intervention on addressing health disparities and inequities can go unseen without a focus on health equity and evaluation efforts. That's why we partnered with Emory Prevention Research Center to develop a health equity-oriented evaluation and provide evaluation capacity building, technical assistance, and resources to the 11 community coalitions throughout rural Georgia. Programs and policies do not affect everyone equally because of economic barriers, differential enforcement, cultural barriers, community relationships, and implementation challenges. Health equity-focused evaluations can help determine if your program is reaching the underserved population that is experiencing these inequities. Evaluations can be designed to help us understand what works, for whom, under what conditions, and reveal whether health inequities have decreased, increased, or remained the same. This is important because population-wide strategies to improve community health can lead to overall improvements in health, but at the same time, inequities may widen, and your evaluation should be sensitive enough to capture this. To address equity in evaluation, we need to integrate health equity considerations throughout each step of an evaluation. In the interest of time, I'm not going to go into detail on each of these steps, but I will recommend that if you're interested in reading more about addressing equity in each of these evaluation stages, that you go online and download the CDC's Practitioner's Guide for Advancing Health Equity. And there's a full title at the bottom of the slide. So the Two Georgias Initiative evaluation uses a mixed methods approach and has two levels, a site-specific evaluation and a cross-site evaluation. Both the site-specific and cross-site evaluations use these mixed methods, including surveys, key informant interviews, focus groups, tracking tools, and program documents as the main data sources. The site-specific evaluations were developed by the local evaluator from each site and focused on the unique aspects of the local program, and data are collected locally, focusing primarily on people or groups directly impacted by the implemented programs. The cross-site evaluation, led by the team at Emory Prevention Research Center, uses an evaluation plan that focuses on what is common across all of the sites, as well as key equity outcome indicators. So the main point of this presentation is to highlight the equity-oriented tools and resources that were provided to the rural community coalitions. Over the next few slides, I'll walk through three different tools: the potential equity indicators list, the community change tracking tool, and a community-based survey that was used to collect primary data. So the first tool is a list of potential health equity indicators. This extensive 10-page list provided guidance on potential measurable categories of health equity outcomes and their respective data source. Relevant indicators were identified early in the planning process to ensure sufficient data on populations experiencing inequities could be gathered, tracked, and analyzed. Categories include economic, education, social, health and healthcare, neighborhood and built environment, health behavior, and health outcome factors. I realize the screenshots on here are really small, but this document will be available for download in the files section in my session. So these indicators were pulled from several national and regional sources like Healthy People 2020 and the Metro Atlanta Equity Atlas. And of course, there are always considerations when selecting indicators to be used in an evaluation. Are the indicators sensitive to change? Is the data readily available, or is there lag between collection and release date? And are comparisons possible across different data sources? So these were all taken into consideration as each coalition selected which health equity indicators they would or could include in their evaluation plans. So the second tool it provided to the community coalitions is the Community Change Tracking Tool. This system documents steps toward and actual changes in policy, systems, and environmental changes by each coalition. The system asks local project coordinators every 6 months about each strategy identified in their community health improvement plan, including its current status, critical events in its implementation, current reach, potential reach over time, and how it addresses health equity. This slide shows a screenshot of the dashboard type page that gives us a sense of what changes each coalition is working to achieve and the status of each change. Along the left side, under the PSE change heading, there are a list of community changes that a particular site is working on. These were pulled directly from the Community Health Improvement Plan and other program documents. And Emory worked with each site to develop their list of PSE changes. So as you can see, for each change, there is a space that says whether the change is active, not active, or completed. If it's not active, it's either because the work has not started yet or the strategy has been dropped. If it is active, this means the site has started working on it, but has not achieved a change yet. Beyond this dashboard, there's a page for each PSE change in the list that includes more details on the status of the change. The last tool I want to share with you all today is the community-based survey. Unfortunately, much existing secondary data is not useful for assessing change resulting from the initiative due to the small sample sizes in the rural communities the coalitions serve. Therefore, Emory developed a community-based survey using common equity outcome measures to attempt to measure change at the local level and allow for comparisons with regional, state, or national data when possible. The data generated serves to answer the outcome evaluation question: has greater health equity been achieved as a result of the initiative, and for which outcomes, along with several other outcome questions. This mailed self-report survey was sent to 11,406 households, random households, in each coalition's county, and will be used as baseline data. I'd like to emphasize that this was a huge undertaking by the Emory evaluation team of 6. Each letter that was sent with the survey was hand-signed by the PI, Dr. Michelle Kegler. So she spent a lot of time signing her name. And there were 2,788 completed surveys, resulting in a 24.4% response rate, which is really good for a mailed self-report survey. All surveys included questions on demographics, well-being, health status, and quality of life. And depending on coalition priority areas, the survey modules could include social capital, addressing healthcare access and utilization, healthy eating and food access, and physical activity and access. Each coalition received their county's results in 2 parts. Part 1 showed the survey response by question, while Part 2 showed key survey questions stratified by race and/or income. Doing this helped each coalition better understand and address where inequities existed in their communities and how they could respond. These data are being actively shared in a culturally sensitive way with partnership members, stakeholders, and community members. The findings in this report may serve multiple functions for the coalitions, such as supporting future grant applications, providing a baseline understanding of community-level access to healthcare, healthy environments, and health behaviors. It could also inform implementation-related decisions and priorities, and assess change if follow-up data are collected. And a second community-based survey will be going out to the 11 sites starting later this year. So we will have that follow-up data. And like with any survey, there are limitations. The community survey data have some potential limitations, including that the data are self-reported. This self-reported data is susceptible to over-reporting of good behavior and under-reporting of bad behavior. So answering questions in a manner that will be viewed favorably by others, and reporting previous events and/or experiences inaccurately or by omitting details. And second, certain types of people may have been more likely to complete the survey than others. So compared to the 2017 US Census data, certain demographic variables were under or overrepresented among the survey respondents. And last but certainly not least, here are a few key themes and takeaways from the initiative thus far for us. First, it has taken a lot of time and patience, and we understand that it will take even more time and patience. Change does not happen overnight, and we recognize that, especially with the pandemic happening last year and continuing on. Second, we've had to be flexible with what success looks like, especially as it relates to achieving health equity, working with each partnership and getting them to think past program and about community-wide change and what that success could look like. And in doing our research, we found that there is a huge absence of best practices in measuring equity and an even larger absence in measuring equity in rural communities. It's why we are deeply invested in this initiative and in supporting and documenting promising approaches to improving health and measuring and evaluating how these communities are advancing health equity. Capacity building and creating a learning community is key. The partnerships we funded have not only increased the number of partners they work with within their county, but they now have monthly calls with one another across the state without our involvement. They're sharing program ideas and evidence-based strategies, talking about barriers and how they've overcome them, and sharing policy ideas and efforts, which leads nicely into my last takeaway, which is we have heard from several coalitions that if it weren't for the capacity building and resources we've provided them with, that they would not have been able to respond to the COVID-19 pandemic in the manner in which they have. They are working to adapt their programs and evaluations to include COVID-19, and of course, it will be captured in our cross-site evaluation as well. But thank you so much for joining me today. Here is my contact information. Feel free to reach out with any questions, or if you'd like to learn more about the evaluation tools and resources that we provided. Thank you.